thought they had a blue wall.
Different neighborhood down here.
We're live. Oh, we're live.
Different neighborhood. Yikes.
Welcome back, everybody. It's the afternoon, still January 7th, and we have in with us our spectacular JFO, Nolan Emo, who is gonna, we heard about this yesterday, when they were giving us updates around HR1. And frankly, this is one of the largest, and it's one of the tangible things that we know we're going to lose. So I thought it would be great if Nolan could give us a refresher on what provider tax is and do a little bit more in depth, because I think it's not understood well.
So for the record, Nolan Lionel, the Joint Fiscal Office, do you want me to talk about, do you want me to go in depth on FMAP?
I want you to do both FMAP because we always need refreshers on FMAP. And I'm looking forward to your slides that have the dollar signs and the.
I've got
and the
those.
dots.
I'm gonna do a really,
Vermont orders.
have the Vermont water. Okay, so I'm gonna do FMAP fast because you only have 45 minutes. And then I'll move into provider tax. You will have lots of questions. I would say 90% of them will probably be answered in future slides.
Okay.
So maybe for the first one,
We'll see.
well, we can play it by ear.
Okay.
But I just want to say, like, because of our time, we don't want to over question, especially because the answers are always there ahead of us.
We have your slides on our.
Yes.
website.
Yes.
Refresh.
Oh, there they are. I just didn't scroll down far enough. Sorry.
So before we talk about provider tax, I think it is helpful to talk about FMAP. FMAP means Federal Medical Assistance Percentage. And what that is the formulas for how the federal government matches state dollars in the Medicaid program. So just from a state budget context, the fiscal year 25, the state appropriated $9.2 billion total, the total state budget. 2.4 billion of that total appropriation was Medicaid. So, and when you think about it from a federal state standpoint, of our total appropriation, the total 9.2 billion appropriation, approximately 3.2 billion or 34% of the total state budget are federal dollars. About half of those federal dollars are for Medicaid. Just again, to give you some context of the spend. Overall, Medicaid expenditures, again, 2.4 billion. Medicaid, for those who remember, is a state-federal partnership. At some point, I would like to come back in and do a little bit more conversations on global commitment if people want a refresher on global commitment, what it is. But not all the federal funds. So the pie chart on the right is just like, here's our share of state dollars versus federal. So overall in Medicaid, 62% are federal dollars, 33% are general fund, another 4% are just other things, right? Not all of that's FMAP. Sometimes we have some pure federal grants in there, but it's mostly FMAP. So federal match dollars range between 50% and 90%, depending on the program and or the expenditure. So FMAP is the share of state Medicaid benefit costs that are paid by the federal government. It is a very complicated formula, but the dumbed down version of how I understand it, and we'll try to explain it to you, is it's basically a formula that looks at things, but essentially is calculated based on a 3-year average of state per capita personal income compared to the national average. So every year we get, the federal government tells us what our FMAP is. They're the ones who calculate it. When our FMAP goes down by 1%, we're always like, oh no, we have to find another $18 million just to maintain the same level of service. And then next year it might go up by 1%. Like, sweet, we have $18 million. The thing that we forget is that if our FMAP's going down, it actually means that our per capita income is getting a little better. So when the FMAP goes down, it's actually something that our economy is doing a little better. So it's this weird thing to put, we from state's budget standpoint, we're like, oh no, we have to find $20 million just to maintain the services. But it's also reflective of a bigger picture. Just be mindful of that. The other rules are that at the federal level is that no state can receive less than 50% or more than 83%. So who gets 50%? Those are the states that have high per capita income.
Interrupt you for a brief second and ask, just because of what you were talking about there around, if our FMAP goes down, it means that we're doing better as
On average compared to other states.
compared to other states. Has there been any tax analysis done? If our FMAP goes down, whether or not our tax receipts are going up because
No.
people are doing,
There's never been a look at
there's
that.
never.
But I once looked at it and I compared it to the trend based on recessions. And there was a link. Where I did see a correlation.
Yeah.
I don't know what the correlation was, but I did notice a trend that would make me scratch my head and say, that's a great project for a graduate student to do. But the tax department has never really taken the time or neither way to compare it because
I just didn't know if maybe we saw an equivalent
no,
increase in tax receipts,
no.
personal income tax receipts.
But I did, like I said, I have seen a relationship, a correlation, which is different, between recessions and our FMAP rates or the trend of our FMAPs.
Sorry to interrupt you.
No, that's fine. So states, just for comparison of what other states are doing, other states have, so the states that have high per capita income, California, Connecticut, New York's, New Jersey, they're all 50% FMAP. Then you have states that have low per capita, Mississippi, West Virginia, Alabama, you can see they're in like the 76%, 74%. We're kind of in that middle. And on the left side, you see other compared to other New England states. So Connecticut, New Hampshire, Massachusetts, they're at 50. Rhode Island's 57.5. We're at 59.01. This is for federal fiscal year 2026. Maine's at 61. And if it has an up or a down, that means their FMAP went up from the previous year, went down from the previous year. I have another chart on a different slide that shows you like the trends of them going up and going down. Actually, I can show you that. Oh, that's later. This is the slide that you were excited about. And basically, I think this explains it pretty well. Notice the Vermont quarters.
Nice touch.
So, and it's funny because I never said anything, and I think Representative Black was like, "Hey, those Vermont quarters," and I was like, "Look, somebody noticed," but nobody noticed it for years. So,
Can I share something personal here? I just want to say, and I'm putting this right out here. I remember the very first time I met Nolan on Zoom and he had his little FMAP quarters and everything. And the thought in my head was, does this guy think that we're so dumb that we need a visual coin and dollar representation? And then I said to myself, oh my gosh, I love this. I really do need this. Anyway,
And yes, we are that dumb.
I don't do it because anyone is dumb. I do it because it's fun.
it is.
That's a great visual.
It also enhances learning to have
For sure.
multiple media representations of info.
Yes.
I'm a visual person.
And pretty soon those pennies gonna be in use.
We can add sound if you want. Now. It can be like, choo, 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 like.
Just visual, not verbal, not oral. All right, so we have multiple FMAP rates. We have our regular FMAP rate, which is most of the Medicaid program gets it at 58.81 for federal and 41.2% for state. So what does that translate to? For every $1 we spend in the Medicaid program, we get another $1.43 match from the federal government for a gross of $2.43. Gross is always the federal and state combined. You're going to hear me say that a lot, gross. So here's the double-edged sword. When we cut Medicaid, we cut $1 out of Medicaid, we lose $2.43 in services, right? It goes both ways. But then people say, hey, we're leaving money on the table. Why aren't we putting more money? Well, because every dollar we don't put into that, we lose that elsewhere, right? So like it's just a conversation that's been had. I'm just throwing it out there. We also have our enhanced FMAPs. So we have the Children's Health Insurance Program. Remember before when Stephanie was talking about these eligibility groups? And so in Medicaid, when you're on Medicaid, you just have a card that says Medicaid. Or if you're a kid, just says Dr. Dinosaur. But behind the scenes in the administrative structures, we care about what door did they come into to make them eligible? Were they low income? Were they disabled? Did they hit a certain threshold? For our children's health insurance program, there's 4,400 kids. That's a certain eligibility group. So they get a special match. Now, they're just considered Dr. Dinosaur on their card. They don't know they're a CHIP kid. But from the administrative side, we're getting extra match on them because they meet certain criteria. Now, another confusing thing is that CHIP isn't actually part of Medicaid at the national level. It's in a different statute. But we administer it through our Medicaid program, so we consider it Medicaid because it's under our Medicaid, actually Dr. Dinosaur umbrella. Then we have childless new adult. Don't let the name fool you. These aren't new adults. They weren't freshly adultized. It's just a name, but this is the expansion under the CARE Act. This is the expansion of the childless adults. At the time, they were like new adults, the program. They actually were already on our program, but under a Catamount or something else. But this is just the name that was assigned at the time for that Medicaid eligibility group. That's what we call it. It sounds confusing. New adult, they're not new. It's just a name. Don't read into it.
Who was it?
It's new. It's low income childless adults who were not previously eligible prior to the Affordable Care Act. So those people were either on BHAP or Catamount back in the day.
Or didn't have insurance.
Or don't have insurance, exactly. We're getting a 90-10 on that group. Now, it was weird because, bless you, when the expansion happened, states like Vermont were getting 80-20 on that group. And states like Mississippi that did not provide any coverage for them were getting 100% match on those. They were paying $0 on that. And over a period of years, they got less, we got more, and everybody's at 90-10 now. That was how it was passed at the time. It's 90-10 in perpetuity until the law changes. Because people say, how long is that going to last? It's just until the law changes. So that's the match we're getting on that particular group.
And I love thinking about the slide because when they presented to us, Monica presented to us yesterday, it's almost as though the new adult category are the ones that are targeted in HR 1 to sort of lose eligibility. And so for every person that we're not covering because they've lost eligibility, we're not spending that dollar and we're not getting $9 back. It's a lot of money.
This next slide is the 27 rates. These are the rates that so the 26 rates are what you're looking at for budget adjustment, because that's the current fiscal year. When the administration releases their budget for fiscal year 27, these are the FMAPs that they will be using. So I got those numbers. I created a new slide, found some more quarters.
So we actually went up. Am I interpreting this right?
No, it actually went down. It went down.
0.93.
It went down by a nickel.
On the
41.2.
previous slide, you said we were at 59.1.
Yeah, so the FMAP went down. The federal share went down.
Oh, that was this year. Okay.
Yeah, so it's roughly a nickel less for every dollar we spend, right? A lot. It's like 5%. So, and then this slide I'm going to keep it brief because this is just the history of FMAP, right? So this just shows you the top one just kind of shows you like the trends, and then you can see we got during the American Recovery and Reinvestment Act, we got a bump, and then the Affordable Care Act, we got a Leahy bump, right? And then so that just kind of shows, whenever the states have been in recessions or whatever, FMAP is an area that the federal government has traditionally looked to help states stabilize their economies. And then on the side there, this is this trending I was talking about, where you can see if it's gray, that's where the FMAP from the federal side decreased. And then the white is where it increased. So you can see it goes up, it goes down, it goes up, it goes down. And then the side there just shows you when we've gotten, enhanced maps, FMAPs, and those are usually tied to some event, right? So the American Recovery and Reinvestment Act was during the Great Recession, right? So anyway, I want to move on to provider tax, because we're running out of time, but this was really meant to be just a kind of a quick primer. Let me find that one. Okay. there it is. Okay, everything you ever didn't want to learn about provider taxes in 5 minutes or less. So what is, and I have Jen's name on here too, because Jen helped me put together the legal stuff in here. There's stuff about hold harmless and other stuff. And I can just run through it and she can just correct me when I mess it up. So what are provider taxes? So we call them provider taxes, but they're assessments on healthcare providers. And I have a list in the future about what those taxes are and who they are on. But essentially, as I mentioned, Medicaid is a state-federal partnership. The state can use these provider taxes to sort of generate funds, but we have rules. So we tax a provider, hospital, at 6%. We can then take that money, which is, I forget, I probably have the amount that we raised.
Percent on your what?
Their net patient revenues,
Net-
great question, thank you. Excellent question. I do have it later on, but let's say we raise $200 million. You can take that $200 million and you can match it, and now you have 390 million, right? Or something like that. And that's money that you have that you can now use to pay for the system, right? So I have a slide in here that talks about how many states use provider taxes and which ones. But basically, in short, and I'll get into the details of it, it's a mechanism that states can use to raise money to help pay for Medicaid services. But they have to comply with federal law. The federal government says, fine, you can tax these people, but there are limits of how you do it. And that's what was addressed. And I wasn't saying attacked, it was attached to where I was going in HR 1. And so the rules about that have changed. So provider taxes are deposited into the general fund. They used to be deposited into a separate fund, but now they're deposited into the general fund. And the reason I have this slide is it gives you a context of how big the provider taxes are. So in fiscal year 25, general fund accounted for 88% of, so 88% of Medicaid funds were general funds. 25% of those general funds were provider tax.
Wait, say that again?
26.
28.
28%, sorry, I can't read. So revenues from provider taxes are 28% of the state funds. Or if you look at the other side, they're 9% of total funds for Medicaid. Just to give you a sense when you compare. So the left side just shows you, of all the money we raise in the general fund for provider tax, 28% from provider taxes.
That's a lot.
Yes, of the state dollars. And if you look at the whole pie, it's 9% of all the dollars, including the federal funds. So just to give you a sense of the magnitude of how much money we raise in provider tax and why it's a big deal if we lose it.
I have questions, but Alan has.
You get these taxes from healthcare related things. Can you name some of them? Is it?
Yeah, I'm getting there.
doctor? Oh, you're.
I said to you, don't worry, your 90% of your questions will be answered. We are full service here.
Because we just saw Diva with their ups and downs, and they always break it down of total and then general fund.
Yep.
With ours. So if you counted provider tax and took it out of what they list for general fund, how much general fund do we use as a percentage if you took the provider tax out of it?
So I hear what you're going.
Called it something else.
So this always gets to be a funny question in terms of like, I look at the general fund as like a giant pond.
Giant what?
A giant pond.
Pond.
You put all this money into your pond and then you're scooping water out of the pond to pay for your stuff. So in theory, that dollar I raised from provider tax isn't necessarily going directly to healthcare services, even though that's what it's being raised for. right? So, but in theory, it's just going to the general fund, which pays for everything, including Medicaid. Now, if you're to say, okay, this is dedicated to this, you have a number, bless you. I do have a number, and that's in a future slide.
Oh, okay.
Yeah.
So you already saw this slide, and you saw this slide.
Or all the quarters, Vermont quarters.
Of course, it's the same slide. Okay, so this is the Jen stuff, and Jen can either go through it or I can do it. It's up to you.
Up to you.
Why don't I just do it and then you can correct me when I mess it up, which I will. So provider taxes, these are the federal rules. Provider taxes, the federal prem. They must be broad-based, which means they must apply across class of healthcare items, services, and providers. So it can't be like, I tax you, but not you, but not you.
For like primary care. Like, no, what's a class? What would be a class?
Go ahead.
Well, no, I mean, you're gonna get to, I don't know if you've shown the.
I haven't yet, but we're getting there.
Come up on the next page. Look at the next
Jack
page.
Harvey from the Office of Legislative Counsel.
Okay, sorry.
So the broad-based requirement is that if you apply a provider tax to somebody in the class being either the type of provider or the, pharmacy claims or something like that, you have to apply it to all of everyone who fits in that category. You can't.
So you can't tax Copley different than
Right, you
UVM.
can't carve out, we talked yesterday about critical access hospitals. We couldn't say we're taxing non-critical access hospitals, but not critical access.
Could we say we're gonna tax gastroenterologists, but not
No.
urologists?
No, because it's
because there are specific classes.
Classes that we are allowed to.
Which are on the next page.
Oh,
Which I'll get to, you're right.
And
Okay.
don't get excited about taxing new ones, no one's gonna get to.
Yeah.
I'll get to why it's complicated. Okay, so they must be uniformly applied, so the same licensing fee across the class, same per bed licensing fee across the block, same assessment rate on gross net receipts. So it can, again, similar. And you must not hold providers harmless, so it cannot guarantee directly or indirectly that the tax paid will be returned to them and make them whole.
And
So for
that's in
instance,
the federal laws.
yeah, so we can't say, okay, Copley, you paid $2 million in provider taxes, we'll make sure you get that back. You can't. The way they get that back is through their Medicaid utilization. So for instance, so like nursing homes is a perfect example, right? Because they don't all have Medicaid, a lot of them are Medicare, right? So some may pay more in provider tax than they get back, and it all depends on what is their Medicaid caseload. If you're a provider with a low Medicaid caseload, you might pay in the provider tax, but not get any federal dollars back through that because you don't have people that are getting paid to that. Vice versa, you might have a high caseload and you actually get more back, but it's not, you may or may not, but that's an example. Sorry, go ahead.
Is there a requirement that it goes back into the healthcare system since it's in the general fund?
It's not a requirement, it's what we're using it for, and there's limits for what we can use it for or how we use it. Right, so if we tax the providers, there's certain things we cannot do with it, right? Jen, am I saying that correctly? Like we can't, and there's also rules, I'm getting confused here, but there's also rules of like there's taxes that we think we're doing, but might actually be considered provider tax. So you just have to be very careful around provider taxes. So in theory, we are using it for general fund, but it's going into it's going to the general fund, but there are parameters for how we spend that particular amount of money with the rules. And I'd say, see slide 11, which is where the changes are. So here are the provider classes that Jen was talking about. There are 19 classes of provider taxes. If it's red with a little star, that means we currently assess it in Vermont. So inpatient, outpatient, that's our hospital provider tax. We kind of combine that. Nursing facilities, that's our nursing homes. Outpatient prescriptions, we have a drug prescription provider tax. And then we have EMS. We used to have home health. We eliminated that several years ago. And then we also have one on this intermediate care facilities, but we don't actually have any intermediate care facilities anymore, so it doesn't really count. So those are the classes that we can. So to get to your question about gastrointestinal, they would be covered under physician services, or if it's provided in a hospital, it's covered by the hospital provider tax. Because it's part of their net patient revenue, how that money is calculated. So services that are provided in a hospital all count as provider tax.
I can.
Please.
So the question about could we have taxed one type of physician and not another type? No, because it must be broadly based across the whole class of physician services.
Oh, and to get to the other thing that Jim mentioned, comes up, why aren't we taxing more? So, under the Shumlin administration, there was a proposal to do dentists. And the reason it sort of fell apart was because, so with the industries we regulate, nursing homes, hospitals, A, there's not a lot of them, and B, they're all regulated by the state and they have to submit financials. So we know how much net patient revenue hospitals have. We know how much nursing homes have. We know how much the home health, when they were EMS, we work with them and they provide us with this information. There are hundreds of dentists, different practices. They don't have audited financial reports. They're private companies. Nonprofits have audited financial reports, your home health, but dentists are private. They don't have audited financial statements. So there was no way for us to find out how much they were paid, how much they wanted to pay. So in order for us to tax dentists, we would need their cooperation. Forward to the emergency medical services. They approached the state and were like, we're interested in provider tax. Not all of them were, but most of them were. And we work with the industry for them to collect that data because they're participating in that process. So if we want to, and also some of these may not provide a lot of revenue. So it's a lot of juice for the squeeze. So if we want to do provider tax on dentists, okay, well, several hundred, let's say there's 100 dental offices, we might have to create this whole administrative structure and we may not raise a whole lot of money out of it. Is it just worth the squeeze? May or may not be. So there was a study done in like 2011 that actually looked at this, how much would be raised if we taxed each of these and what would go into it. And it was a very interesting study. I mean, it's outdated, but it's still relevant in a way. Because the administrative complexities of it still apply. So here is what we pay or what we receive. So, and these are the rates. So the hospitals are taxed at 6%. In fiscal year 25, we raised $212 million in provider tax. This is the majority of provider taxes. Fiscal year 26 is forecasted to be $225 million. So we're expecting it to go up another 13 million. Nursing homes, they're actually, when the nursing homes provider tax went into place, at the time when it was being negotiated with the industry, they were like, it's way easier for you to calculate provider tax based on per bed basis. It's still roughly 6%, but it's easier for them to calculate on a per bed basis versus their net patient revenue. So that's why it's done that way, but it still doesn't go over the 6% threshold. When we raise, it's pretty steady too. It's 14.4 million, almost to the dollar, give or take 100,000 every year.
So that's per bed, regardless of whether someone's in it or not, correct?
Yeah, that's the bet. That's my understanding.
Okay.
Ambulances are 3.3%. Why is it 3.3%? That was the rate that was determined to raise the amount of money that was needed at that time. Now, as a full fast forward to HR1, we cannot raise that any farther. So 6% is the max, but the ones that are below 6%, we now, because of HR1, we cannot increase provider taxes at all. We can't institute any new ones, and we cannot raise them. Intermediate care facilities, it's still on the books, 5.9%. We don't actually have any more intermediate care facilities anymore. There's a 10-cent per script for pharmacy that raises about $875,000 per year. And then home health sunset in 2023. So the total provider tax estimate is 229 million. Like I said, the majority of that are hospitals. They account for 93% of our provider tax. Just to give some context, go ahead.
I'm thinking about what's coming over the next 5 years.
I'm getting to that.
Okay.
Can you hold it for the last slide?
Yeah.
Okay. Context. Provider tax have long been associated with the Medicaid programs. And this is according to Kaiser Family Foundation. Now they just go by KFF straight. In 2004, 35 states had at least one provider tax. By 2024, 49 states and DC had at least one provider tax. The most common type of provider tax is actually nursing home provider tax. There's 46 states. 45 states have hospital provider taxes. And approximately 13 states, including Vermont, had provider taxes greater than 5.5. 20 states had provider taxes that were lower than 3.5 on hospitals. And then 32 states had intermediate care facilities, just to give you a sense. Now, everybody's going to be frozen into those rates. No new provider taxes and cannot increase the rate. Impacts HR 1. So there is going to be a phase down over between 2028, federal fiscal year 2028 and 2032. In Vermont, only the hospital provider tax is actually affected. That's because nursing homes are excluded. There was another one, home health, I think, was also included. Oh, intermediate care facility, that's right, it's in there. Those two were excluded. But ours were below so those were excluded, sorry. And then we have an ambulance provider tax, but it's 3.3%. So it's below the 3.5% threshold. So really the only one that's going to be affected is the hospital provider tax. That said, it's the biggest one. This is the impact. This is the estimated impact over time. These are a little bit different than what I actually presented to you yesterday. They're similar, but they're different. And these are my estimates. And not that we dispute each other, we just haven't come together yet to say, this is our agreement, right? So it kicks in fiscal year 28. We're expecting a $15 million hit the first year, and then 35 the second year, and 57 the third year. And of course, these numbers continue to move. But by my current estimates, by 2033, we would have $113 million less in provider taxes. So this is my estimate based on the calculation. This will evolve. These are the numbers that will probably be in the e-board that are coming up. And as we get more information or as it gets instituted, these will evolve. These are the preliminary estimates of what we think the impact will be based on. Now, those could change based on changes at the federal level. They could change based on any policies we make. They could change based on all kinds of things. But this is my current preliminary estimates. I cut you off. What was your question? Sorry.
Well, my question is, lots of questions but you won't be able to answer, and we probably should answer of where can we make up this revenue? But in the vein of where we can make this up, if the providers are paying 3.5% less than they were before, shouldn't there be a commensurate drop in the rates that Medicaid pays them? Because while the state is losing that 113, that 113 is staying with the providers as revenue. They're not paying it out in a tax. So it's going on their bottom line.
And I've had this question asked.
Cutting them by $113 million.
I think it's a complicated answer, and I don't think that I can answer it other than to say that, the hospitals pay $200 million in provider tax, but I don't know what their total Medicaid gross reimbursements were. I guarantee they're more than $212 million, right? So that goes to show that hospitals are probably getting that money back to the match. Now, again, I don't have those numbers, so I can't say that. I don't have the answer for that. Maybe I'm wrong. Maybe it's not getting, maybe they don't pay $220 million on Medicaid. I don't have that number in front of me. But I mean, it's a good question, but I don't think it's that simple, unfortunately. But that's something I would have to look at. I think it's also something that Voss probably has strong opinions on. But what I would say is $113 million less general fund. If you take all that general fund out of Medicaid, you lose all that match. So you're going to lose $300 million in spending.
In spending power.
Now, your levers to your other question are raise revenues, cut services, or shift general fund from other areas of government. So you make the cuts in other areas of government. And I think the answer will probably be, you're going to consider all of those.
Oh.
So, because you'll say, okay, well, this dollar is only $1 in Fish and Wildlife, but it's $3 in Medicaid. But again, that becomes down to legislative and executive decision-making.
And it's only, and I use the word only, 113 million loss in general fund, but ultimately it's over close to 300 million loss in the total budget,
Yeah.
the federal funds.
While I can't speak to the motivations of the federal government, what I can say is that in HR 1, they assumed savings in FMAP having to be paid out to states because of this. They have made assumptions around that states are going to make cuts in Medicaid and they will save money on the FMAP. That's where this is coming from. It's coming from savings at the federal level, because that's where they assume. I can't say it's their motivation, but they've booked it in the offset savings. And this is a big one, because you look at states like California, their numbers, someone once said that our budget is budget dust compared to California. It's a rounding, we're a rounding error.
Budget dust.
Budget dust. Our total Medicaid budget is a rounding error in California. But at the federal level, when you combine all the states, that's a significant amount of money that the federal government can assume will be clawed back, whatever you want to say. So again, I won't speak to the motivations. I can just say they book savings under the assumption that states will make Medicaid cuts to offset the loss.
Thanks.
Isn't that exciting? Aren't you happy now?
Yeah, go ahead.
I had one and I'm not quite sure how to articulate it. But your projected estimate is it's just half of what we have now. And so it almost seems like it's constant, like you're assuming constant revenues over that next 5-year period.
Well, think about it. Yeah, so I'm assuming that, so it's based
So
on,
I'm gonna finish the question though. So we're assuming healthcare costs and whatever won't go up.
no, I'm assuming they do go up.
Okay, but why wouldn't the provider tax then go up?
I do assume provider tax goes up, but it's also cut. So each year goes up by 0.5%. So I'm assuming a 3% growth, but then a 5%, 0.5 cut, 0.5 cut, 0.5 cut. So there's growth built into the base in terms of we're taxing net patient revenue. I assume that that's going to grow at 3%, but then we're losing 0.5% every year. So, and it's half because we're at 6% and then we're going to be at 3.5%, but there's growth in that base. It's a good question. But we're not assuming that spending may go.
Yeah, good, thank you. Well,
I mean, again, there are a lot of moving pieces. These numbers will,
Yeah.
next time you see me, that number might be 110, it might be 120. It's the current thinking. It's a great question and it's going to continue to evolve.
Thank you. Everybody totally gets the provider tax now, right?
Oh, yeah.
All right, we can go off of live.